Okay. Let us start the discussion. INICET 2025 Predictor series. So we'll see the probable topics and most commonly asked topic, because INICET exam questions and topics, they are very predictable. So you can say what topics are used, but questions may be twisted, but generally topics will be the same. So one favorite topic for most of the examiners is ABG. So in that ABG, very importantly, interpretation, and also high anion gap metabolic acidosis versus normal anion gap metabolic acidosis. Now let us see. This is the ABG, very simple. pH 7.15, bicarbonate is 12. Now there is a patient with polyuria, polydipsia, drowsiness. So it can happen in multiple situations, but what is the ABG showing? So it is reduced, CO2 is not given, but still anywhere decrease in pH is acidosis. This bicarb is also reduced, so it can be metabolic acidosis. And always I tell, when it is metabolic acidosis, usually the differentiation is based on high anion gap and normal anion gap metabolic acidosis. Now how do you calculate anion gap? It is sodium, the formula, this is very important, minus chloride plus bicarbonate. This is the standard formula. How much is chloride? 95 plus bicarbonate 12. So it is 135 minus 107. So how much is the anion gap? Anybody from the audience? Normal anion gap is 8 to 12. So normal anion gap is 8 to 12 milli equivalents. So this anion gap, it is somewhere 28. So it is high anion gap metabolic acidosis. Out of this, which will cause high anion gap metabolic acidosis? It is DKA, because the diarrhea is usually normal anion gap metabolic acidosis. RTA is usually normal anion gap metabolic acidosis, whereas vomiting is usually metabolic alkalosis. Everybody should be thorough. Whenever a condition is adding acid, it is high anion gap. Other all will be normal anion gap metabolic acidosis. So this is something you need to know. First, when they give you any ABG, after seeing clinical history, see the pH. Is it acidosis or alkalosis? And by direction of change, if it is in same direction, it is metabolic, change in pH with respect to parameters. Change in pH with respect to parameters, opposite, it is respiratory. Then after identifying the primary disorder, compensation. Primary respiratory, we see metabolic compensation. Primary metabolic, we see respiratory. If given and expected or correlating, it is simple acid base. Not correlating, it is inappropriate, it is called as mixed acid base disorder. Just a brief revision. And calculation of anion gap, this is the standard formula. And finally, taking into consideration the clinical history. Clinical history, there was polyuria, polydipsia, drowsiness. All this can happen in background diabetic ketoacidosis. Then this is also another simple question. A patient on diuretics presents with confusion. This is the ABG given. What is the disorder? See, these days ABG questions are being asked in a very simple manner, not so complex, but know the algorithm and be thorough how to identify the primary disorder within seconds. Just to draw arrow marks. pH increased, CO2 increased, bicarbonate increased. Now anywhere increase in pH is alkalosis. Change in pH with respect to parameters, it is in same direction. So what should be the name? Metabolic alkalosis. So this is the best answer. Always in ABG, be thorough about identification of primary disorder. Second point, how do you calculate anion gap? Third point, high anion gap, normal anion gap, metabolic acidosis, what are the conditions? Then next important topic is spirometry. They can ask you questions like this. There was a patient with ILD and he underwent spirometry. Which of the following pattern? You know that ILD by definition, it is restrictive pattern. Now when do you call it as restrictive? So the ratio FeV1 by FEC should be normal or increased, whereas it is a small lung, FEC should be less than 80% of predictor, should be less than 80% of predictor. So if you notice here, the best answer ratio is elevated but FEC is reduced. This will be the best answer. Now spirometry, again it is totally algorithm based questions. You should know when they give you any spirometry question, what is the first parameter? You should see ratio. If ratio is low, your answer should be, what is low ratio called as? Low ratio is called as obstructive pattern. If ratio is normal or increased, still it can be normal lung or restrictive. How is a normal lung different from small lung? The size is less. What indirectly signifies size in simple spirometry? FEC. FEC will be less than 80% of predicted. Now if it is obstructive, you do a test called as bronchodilator reversibility, and if it is reversible, what should be your answer? Your answer should be asthma. If it is persistent airflow limitation, it is COPD. And if it is restrictive, small lung, is it directly due to the parenchymal shrinking, especially in those with fibrosis? What are all causing fibrosis? ILD, occupational lung disease. Extrinsic, here your lung is healthy, something outside is not allowing your lung to expand. Kyphoscoliosis, neuromuscular disorder, very important. Again, in COPD, especially emphysema is commonly asked. Emphysema is one with hyperinflated lungs. Lungs become very big due to air trapping, hyperinflated lungs. So this increases the total lung capacity, and due to involvement of alveolar capillary wall, there can also be reduced DLCO. See, in asthma, apart from this, DLCO can be normal or increased, but COPD emphysema, DLCO is generally reduced because COPD is happening distal to terminal bronchiole. That is the area where gas exchange actually happens. So the diffusion capacity is directly reduced. Then same pattern, which of the following is not a feature of emphysema spirometry? We know that emphysema is nothing but COPD subtype. So it is an obstructive lung disease. If it is obstructive lung disease, they are asking not a feature. What all can happen in obstruction? This can happen. This can happen. Persistent airflow limitation. But emphysema is characterized by increased TLC. Emphysema is not characterized by decreased TLC. They can also modify the question like this. They can give you a clinical scenario based, and they can say he is having alpha 1 antitrypsin deficiency. Instead of smoker, they can say alpha 1 antitrypsin deficiency. What do you expect on spirometry? Same thing they can ask. All can be expected on spirometry, except again it is the same concept, but to confuse you, they might mention alpha 1 antitrypsin deficiency, because alpha 1 antitrypsin deficiency is a genetic cause of COPD emphysema. Next question. There was a patient with severe ARDS. Is on mechanical ventilation. Because it is severe ARDS, even after giving oxygen, there is no much improvement. What is the most appropriate next step? Now keep this in mind. ARDS is INICET favorite topic. They can either give you pancreatitis situation, and they might ask you, what is this patient having? Then they might ask you, how much is the tidal volume that you should give? Low tidal volume, mechanical ventilation. They might ask you, not improving, what to do next? So to improve oxygenation, there are two methods, either increase FiO2, increasing PEEP. So generally there is a combination. So we try to increase both together, but usually to avoid oxygen toxicity beyond a point, increasing PEEP is generally a better option. So this is how. If oxygenation not improving, you should either increase FiO2, increase PEEP. Here PEEP will be more important. If a patient is improving, to avoid oxygen toxicity, first decrease FiO2. Improving. This is very important. Improving, you should decrease FiO2. Then followed by PEEP. Okay. See, already on mechanical ventilation, what is the point in increasing to 6 ml? Here we don't know now, because any fellow who has put on ventilator, he starts with 10 ml per kg body weight. 10 ml per kg body weight. This is where you get filtered in INICET. INICET tests your logic. It feels that this fellow who is writing the exam already knows that routine ventilator setting is 10 ml per kg. 10 ml per kg. So they have not given, yes, mini. This is how you get filtered. PaO2 is given. You leave SpO2. They have directly given ABG value, which is more accurate. So PaO2 is very less. Normal PaO2 is somewhere 80 to 100. Increase in respiratory rate, the indication is when there is lot of CO2, you want to wash out CO2. Okay. So increase respiratory rate to wash out CO2. Already FiO2 is 100%. So still he is not improving. So you should, no point in decreasing FiO2. Only thing which can increase oxygenation here is increasing PEEP. So these questions are very simple. They are based on logical guidelines. So if you get confused at exam, it will be problematic. Not improving, important is increasing PEEP. Improving, important is decreasing FiO2. So you follow this principle, 90% your answers will be right. Then a 40-year-old patient with suspected ARDS is admitted to ICU. Which of the following is not part of Berlin definition? According to Berlin definition of ARDS, onset within 1 week is true. PaO2 by FiO2 less than 300 is true. Bilateral infiltrates is true. It is a non-cardiogenic pulmonary edema. Keep this in mind. ARDS is a non-cardiogenic pulmonary edema. Obviously, PCWP will not be elevated. Now, these are the rules of ARDS diagnostic criteria, also called as Berlin. We have known that it is acute shortness of breath within 1 week. Chest X-ray will show bilateral diffuse infiltrates. It is a non-cardiogenic pulmonary edema. PaO2 by FiO2 generally tends to be less than 300 mmHg. PaO2 by FiO2 generally tends to be less than 300 and it is a non-cardiogenic pulmonary edema. Then try to solve. This is also a clinical scenario based question. There is a 50-year-old male. He presents with 5-day history of dyspnea, chest pain, fever, right pleural effusion. So it is showing features of pneumonia, respiratory infection along with that pleural effusion. So this is suggestive of a right parapneumonic effusion. Short history, you expect infection only, right parapneumonic effusion. So what will be the unlikely finding? Unlikely finding. This is an exudative pleural effusion for your information. And because it is an exudative pleural effusion, Light's criteria, LDH ratio can be elevated. And if it is an infective going into more pus formation, glucose can also be less than 60 mg%. Then this is an infective effusion, the neutrophils can be elevated. But protein ratio will be more than 0.5. Less than 0.5 is transudative range. This is transudative range. Because this is an infective effusion, you expect it to be exudative. They have asked you regarding transudate. Why glucose can be less? Because it is infective. Later, the microorganisms can accumulate. There can be pus and the food for those microbes is glucose. It is glucose. Now, when they give you any pleural effusion analysis by Light's criteria. So here protein ratio should be less than 0.5. And also LDH ratio and is very important, less than 0.6. Both should be less. Here any one of the following, either protein ratio is more than 0.5 or LDH ratio is more than 0.6. If it is transudate, life is very easy. At least you know these three causes. Cardiac failure, right now it is most common cause. Heart disease, kidney disease, liver disease. If it is exudate, malignancy you have to rule out. Infection you have to rule out with gram staining. TB markers, ADA is high. Low glucose pleural effusion, empyema, malignancy, rheumatoid arthritis. And high lipid, high amylase, pancreatitis, esophageal rupture, malignancy. High lipid or white colored effusion, chylothorax. Chylothorax, pleural effusion, triglycerides will be high. Pseudochylothorax, cholesterol will be high. So these are all the various pleural effusions that they can ask you directly in the exam. It is nothing complicated. Just identify exudate and by the given parameter suspect these conditions, students. If it is transudate, life is very easy. Heart disease, kidney disease, liver disease. Then there is a young male with sudden onset dyspnea, and this is examiner's favorite, hyper resonant, no breath sounds. Now see here, whenever there is a patient with acute shortness of breath, absent breath sounds, hyper resonant note, hyper resonance, and hypotension. If you see this combination, if you want, you can consider this as a tetrad. This is not a simple pneumothorax. This is a tension pneumothorax. This is a tension pneumothorax. If it is tension pneumothorax, next step is needle insertion. Needle insertion. Next should always be needle. Next. Whereas followed by ICD insertion. So this is a tension pneumothorax, wide bore needle. See, before doing bronchoscopy, you have to identify this as tension pneumothorax. Bronchoscopy, if there is some clot or if there is some foreign body, it might be helpful in emergency. Here the emergency is tension pneumothorax. Intubation, if the patient is not improving, you may need to intubate. But if it is a reversible cause like tension pneumothorax, if you relieve that compression, patient may actually not require intubation later on. So this is the best answer. This is a tension pneumothorax, acute shortness of breath, absent breath sounds, hyper resonant note, hypotension. So you have 2 A's and 2 H's to identify tension pneumothorax. Then which of the following is true in idiopathic pulmonary arterial hypertension? This is nothing but group 1. So in group 1, definitely MPAP will be more than 20 mmHg. So even if GCS is low, without removing that, what are you going to achieve? So there is a reversible cause. First you put a needle and you can later intubate. So without putting needle, this patient is not going to survive Ridhikataman. Even if GCS is low, if it is a tension pneumothorax, first put a needle, then simultaneously you can intubate. Just intubating without putting needle, there is no point. Then because this is due to direct narrowing of pulmonary artery. So here pulmonary artery will be directly narrowed. So because narrowing, when the vessel is narrowed, the vascular resistance will increase. Pulmonary vascular resistance will be more than 2 Wood units. And there is no heart disease responsible. This is idiopathic. There is no heart disease. So PCW will be less than 15 mmHg. And because the pulmonary vasculature is narrowed, gas exchange will not be proper. DLCO will be reduced. Now you should only select the correct option. So MPAP more is right, this is right, this is right. Something containing A, C, D. So this can be right. A and C are correct. And also if C and D are also correct, I think this will be, this was a recall actually. A, B, C correct is wrong. All correct is wrong actually. So A and C is correct, and also C and D, DLCO is decreased, PVR is also reduced. So few questions will be like this. Then coming to match the following things. Massive pulmonary embolism, they are asking you the treatment. Massive pulmonary embolism, what is the main treatment? It is thrombolysis. So 1 is 3. Pulmonary alveolar proteinosis, what is? Okay, PVR is given less. Okay. So PVR should be more. This is also wrong option. Thank you. So this is just okay. A and C are correct, students. Yes, A and C are correct. So PVR is given less. So PVR should be actually more, because it is direct narrowing of pulmonary artery. So you expect the vascular resistance to increase, because once the diameter decreases, resistance will increase. Okay, pulmonary alveolar proteinosis, what is the main treatment? Whole lung lavage, F. Allergic bronchopulmonary aspergillosis, what is the main treatment? Steroids. Invasive pulmonary aspergillosis, what is the main treatment? It is voriconazole. Invasive pulmonary aspergillosis, main treatment is voriconazole. Now tell me what is the answer. 1 is E, 2 is F, 3 is B, 4 is C. So you should know the treatment of choice for each and everything. Massive thrombolysis, pulmonary alveolar proteinosis, whole lung lavage. Allergic bronchopulmonary aspergillosis, steroid. Invasive pulmonary aspergillosis, it is voriconazole. Okay. Then this is again a commonly asked question, and in INICET, pneumonia etiology, and they'll also ask you severity by curve 65. Now this is a simpler question. A 60-year-old diabetic, fever, cough, right lower lobe consolidation, looking like a typical community acquired pneumonia. Elderly, diabetic, what is the organism? Your answer should be Streptococcus pneumonia. And the main treatment is beta-lactam. Main treatment is beta-lactam if it is for Streptococcus. But empirically, we generally combine beta-lactam with macrolide so that we also cover atypical when you don't know the exact culture report. So this everything is atypical pneumonia. So just a brief summary, students. Whatever happens outside medical facility, community. And the important typical pneumonia in community is Streptococcus. Most common atypical is Mycoplasma. Whatever happens in medical facility, hospital acquired, most common if they ask you, single organism, gram-negative bacilli. If it happens after ventilator, early VAP, simple organism, Streptococcus. Late VAP, it is more complex organism, Pseudomonas. So there is, sir, there are new updates. There is only one update. If score 1 is due to illness of patient, then admit the patient. That's all. Now suppose there is a patient, 30-year-old male, respiratory rate 35, pneumonia patient. Pneumonia is there, rest everything is normal. He is not in uremia, he is not confused, his blood pressure is good. If you go with the original curve 65, the score will be 1 here. Because at that time, we were including all the 65 years. Without only 65 years age more people will develop pneumonia. But now after COVID, we have realized even young people will develop pneumonia. So any pneumonia patient who is sick, if respiratory rate is more, BP is low, you should admit. So that is the only update. Okay. So even if young patient score 1 is also, you should update. You should admit. So admit the patient, and depending upon his stability, you may require ICU. So ICU more than 3, and always ICU you see here, there is no hard and fast rule. You admit him in hospital. If patient is not improving in ward, anytime you can send to ICU. If the score at presentation itself is more than 3, then directly you can send to ICU. It all depends upon stability of the patient. Then regarding lung abscess, all are true except, you tell me, posterior upper lobes and superior lobes are involved of the right lung. Yes. For primary lung abscess, recommended treatment is clindamycin. Yes. Primary lung abscess most common. Yes. Secondary lung abscess arise from aspiration. This is a false statement. Primary lung abscess usually aspiration. Primary lung abscess usually aspiration. And commonly they will also give you this. There is a patient with aspiration lung abscess, air fluid level. What is your diagnosis? Again it is lung abscess. Aspiration, air fluid level. What is your diagnosis? It is lung abscess. Question can be asked like this also. So lung abscess, primary lung abscess, it is due to aspiration. Most common organisms, oral anaerobes. Secondary lung abscess is not due to aspiration. It can be due to some pre-existing lung disease. Already there is some lung disease and patient must have developed it as a complication. Organisms, staph, Pseudomonas. Then there is a sleep disorder. Patient is having high PaCO2 and high AHI. So high apnea, hypapnea index, and there is high PaCO2. So whenever there is high PaCO2 with high AHI, your answer should be obesity, hypoventilation. Now let us see other options. Why it is not narcolepsy? Narcolepsy is only excess sleeping. There will be no problem in breathing. So here in OSA, problem only in sleep. When he is awake, he can breathe. Problem in sleep. Awake, he can breathe. Central sleep apnea also, problem is only in sleep. When he is awake, he can still breathe. In obesity hypoventilation, what will happen is lot of fat in the abdomen and stomach. It will not allow the patient to breathe. So if you see OSA or any sleep apnea with high PaCO2, you suspect obesity hypoventilation syndrome. So central sleep apnea, the problem is in the brain, no ventilatory drive, no respiratory effort, no airflow. Seen in CHF, narcotic use. Obstructive sleep apnea, problem is not in the brain, in the upper airway. It is getting closed. So there is apnea with persisting respiratory effort. And also it is obesity related. Now if you see in a situation, OSA like condition with hypercapnia, don't forget obesity hypoventilation syndrome. This is a very, very important revision slide. So all the sleep apnea identification revolves around these phenomena. Now, which of the following is correct regarding small cell lung cancer? Small cell lung cancer, radiosensitive, chemosensitive, but recurrence is very quick. That's why poor prognosis. Has better prognosis. Which of the following is correct regarding small cell lung cancer compared to non-small cell lung cancer? Has better prognosis. This is false. Small cell lung cancer is more likely to present in the periphery of the lung. Periphery of the lung, this is also false. Less chemosensitive, false. So actually small is more radiosensitive, more chemosensitive. Small has poor prognosis. Small is centrally found. Small is centrally found. So the best answer is option A. So this is a table which will tell you the difference between adenosquamous and small. Adeno, peripheral location, mostly in young males, females, non-smokers, asbestos related. Here the important feature is clubbing and Strozzi syndrome. Whereas squamous, everything starts with letter C. Central, cigarette, cavity, hypercalcemia. Then small, central, it is strongest associated with smoking, rapid recurrence, metastasis, both chemo and radiosensitive. All the hyponatremia, hypokalemia, hypocalcemia. Small means less, hypo means also less. This is very, very important differentiation. If you see hypo, it is small. If it is hyper, it can be squamous cell carcinoma. Then there is a 70-year-old man referred because of 2-year history of progressive dyspnea, abnormal lung examination. He worked as a roofer. On physical examination, there are crackles, clubbing, pulmonary function tests. There is lower lobe fibrosis. Roofer is exposed to asbestos. There is lower lobe fibrosis. Asbestos generally causes lower lobe fibrosis. So this is nothing but asbestosis. Which is found? What is the feature of asbestosis? They are asking. Again, INICET questions will be like this only. They'll give you a big clinical history and you should identify the diagnosis. Diagnosis will not be given. You should only tell what is the diagnosis. From that diagnosis, indirectly they'll ask you a question. Now they're asking you what will be the other radiological feature. This will be pleural plaques because this everything is silicosis. And cavitating pulmonary nodules and masses can be due to malignancy. So we are not suspecting malignancy here. We are suspecting occupational lung disease and the answer is calcified pleural plaques. And this table will make you confident. What you should know regarding occupational lung disease is again INICET favorite question. Asbestosis, pleural plaques, pleural effusion, lower zone fibrosis. Now tell me, most common malignancy is not mesothelioma. It is adenocarcinoma. Most specific is only mesothelioma. Silicosis, upper zone nodules, upper zone fibrosis, lung cancer, tuberculosis, because silica particles can damage alveolar macrophages. And here you see eggshell calcification. co-workers pneumoconiosis, upper zone lesions. Initially, when they are individual, it is simple. Later, they can merge. It is complicated. And what is Kaplan's syndrome called? I want everybody to know what is Kaplan's syndrome. Examiner's favorite question. It is rheumatoid arthritis with pneumoconiosis. So with this, I would like to conclude this session. We have discussed in a very crisp manner the important questions and also the algorithms. The PDF will be uploaded in the app. Kindly go through these topics again and again from your notes. It will be easily done. And these are the list of topics where INICET frequently asks questions. In symptoms, hemoptysis, spirometry, what happens in emphysema, respiratory failure types and gradient, ARDS diagnosis and treatment, pulmonary hypertension treatment algorithm, pneumonia, they'll ask you atypical pneumonia clinical presentation, severity, COVID may be asked, pneumothorax always favorite, tension pneumothorax, what should be done next, bronchiectasis may be asked, ABPA, steroid is the treatment, ILD, UIP, NSIP, asbestosis is examiner's favorite question. These days trending is obesity, hypoventilation. Always evergreen is lung cancer, adeno small squamous, and also anion gap, interpretation and sampling, and recent updates in TB. So I hope we can conclude our session with this. So thank you students, all the very best, keep going. You have reached here with a lot of persistence. Now I want you to complete the exam with a lot of confidence, hoping you will come out with flying colors. Thank you and all the very best students.